This final module will focus on carpal as well as metacarpal and phalangeal fractures. So the scaphoid is the most commonly fractured bone of the hand, and it typically occurs as a patient falls on an outstretched hand which is pronated. The patient will come in presenting with potential swelling and tenderness over the dorsal wrist, with pain and tenderness over the anatomical snuff box, and the base of that anatomical snuff box is this scaphoid. So typically patients who come in reporting that they fell on an outstretched hand and they complain of wrist pain with pain and swelling in that region, you really should be suspicious of a scaphoid fracture. And when this patient has films, plain films, the scaphoid x-ray view is when the patient's fist is clenched and slightly ulnar deviated. And it is very important to diagnose a scaphoid fracture early because early diagnosis is essential to decrease the morbidity associated with delayed diagnosis. Immobilization without surgery is controversial, and the healing depends on where within the scaphoid that it's fractured. After the splint is removed, there's typically a capsular pattern of restriction and painful and weakness of the thumb and wrist extension. So rehab following a scaphoid fracture, active range of motion of the wrist after removal of that splint, passive range of motion for approximately 2 weeks with gentle strengthening and light weights after passive range of motion is started. Need to be a little bit careful at how we progress because we're just very cautious or nervous about potential blood supply dysfunction into the scaphoid region. So that progress is tolerated, but like I said, be aware of the precarious nature of the blood supply for the potential of movement of that fracture line. Non-union in this region occurs up to 10% of the cases, and the slack wrist is also a late complication following a scaphoid fracture. Carpal boss is actually a bony overgrowth or a lump on the back of the wrist, and it's typically at the base of the second and third metacarpal bones where they meet up with the carpal bones. The patient notes that there's like a firm, immovable bump on the back of the wrist or hand. Sometimes it initially resembles a ganglion, but a ganglion is a cyst that is soft and it's movable, whereas this carpal boss is not. And carpal boss is usually present in young adults, typically between the ages of 20 and 40. So normally the index and middle finger CMC joints have limited movement, unlike the more mobile ring and little finger CMC joints. So the index and middle finger CMC joints have kind of a keyed or a close fit, and this may be why this occurs. But why it does not occur in most people is generally is unclear. But the first step when this occurs is activity modification, which usually helps, as the pain often only occurs with a few activities. The patient is usually given painkillers, some anti-inflammatories such as ibuprofen, which has been very helpful for pain. And the patient can be put in a splint that is held in slight extension to try to decrease the symptoms. Moving on to metacarpal fractures. Metacarpal fractures are divided into fractures of the metacarpal head, the neck, or shaft, and the treatment of those metacarpal fractures is based on which metacarpal is involved as well as that location. There's some acceptable angulation, but it varies by location. And no degree of malrotation is considered acceptable. So the incidence of metacarpal fractures is they account for 40% of all hand injuries, and they typically occur in men between the ages of 10 and 29. And the metacarpal neck is the most common site of fracture, and the fifth metatarsal is the most commonly injured. Your patients will typically note that there was a direct blow to the hand or some sort of rotational injury with an axial load. High energy injuries, such as like a car accident, may result in multiple fractures in this region. Wounds in this region can indicate open fractures or other soft tissue injury. And you just want to be careful of carpal compartment syndrome developing. So as I indicated before, there's a certain amount of acceptable shaft angulation with different metacarpal fractures, and that's what this first table is showing you. For index and the long finger, up to 20 degrees of shaft angulation is considered acceptable, the ring finger 30 and the little finger 40. Not that I would ever ask you these questions, but it's just to give you an idea that how much is acceptable for angulation to occur on these fingers following a fracture. So neck fractures of the metacarpal are the most common and then usually occur during motor vehicle accidents, bicycles, or some sort of fist fight. These fractures can interrupt the hand arches and the ability of a person to make a fist. So just going through the different fingers. So metacarpal fractures of the first, or the thumb. So Bennett fractures are fractures of the base of the first metacarpal, and it's intra-articular. It is the most common type of thumb fracture, and it could lead to some instability. Typically when this occurs, a percutaneous pinning is performed, or 6 weeks of immobilization in a spica, but early controlled motion sometimes is allowed. A Rolando fracture is also a fracture of the first metacarpal, but this is a 3-part intra-articular comminuted fracture at the base of the first metacarpal. It is uncommon, but it also has a worse prognosis than the Bennett fracture. Fractures from 2 through 5. Again, we could have a metacarpal head, neck, or shaft fracture. And the treatment is a little bit different based on the location, and you can see that here. A boxer's fracture is a fracture to the 4th or 5th metacarpal. It is an extra-articular fracture, and it could also involve displacement of the metacarpal head. And how are they treated? They're typically treated non-operatively. The patient is placed or immobilized in a splint where the MP joint is kept in about 70 to 90 degrees of flexion. The IPs are at 0. And range of motion to the involved joint is allowed approximately 3 to 6 weeks after the initial injury. Moving on to phalangeal fractures, obviously we could have proximal, inter, or distal phalangeal fractures. The distal fractures are most common, accounting to up to 50%, followed by proximal phalangeal fractures, and then middle, which are least common. And the most common complication following a proximal phalangeal fracture is an extensor lag. So the extensor lag is from the tendon length. So now that if you have a fracture of the proximal phalanx, if the bone length is affected, it can alter the tension on the tendons. So the flexor tendons can become adhered to the callus as the bone heals, and we could get a rotational malunion deformity of the phalanx, or the metacarpal affects fingers coming into a full fist. This is just giving you some pictures of some rotational deformities following phalangeal fractures. On the upper right, you see that this person has a positive scaphoid sign, indicating that the 4 fingers are not migrating or merging onto the scaphoid. The other fingers there have displacement of one of their phalanges. So what are the strategies when somebody has a proximal phalangeal fracture? So if it's non-displaced, usually you could buddy tape, meaning tape it to an adjacent finger. for approximately 3 to 4 weeks, and then we can begin active range of motion. If the fracture is displaced, they're typically treated with K-wire or a plate and screw. We can do active range of motion once that fracture site is stable. They could be placed in a position splint, that's a functional position splint, which can be as described previously. We're going to work on getting the swelling down, doing some joint blocking and composite flexion exercises, working on scar massage as well as mobilization of the soft tissue. Middle phalanx fractures, again, non-displaced fractures can be buddy taped, and displaced can be treated with K-wire or plate and screw. We do gentle active range of motion at approximately 3 to 4 weeks based on the method of fixation to correct that fracture. So that's why communication with your surgeon is going to be big. Some of the additional treatment strategies will be, again, working on reducing the edema, scar massage, working on IP extension with MP flexion. We could do serial casting to progressively improve that range of motion, as well as dynamic splinting. We can do our tendon gliding exercises, which I'll be showing you shortly, as well as blocking and composite exercises. What are some of the complications that we see with these P2 fractures is that we can get joint contracture, swan neck and extensor lag, limited tendon gliding. Some of the soft tissue structures again become adherent to the healing bone. Distal phalanx fractures are usually crush or a jamming incident, and it can involve the terminal tendon, and where it could then avulse off, leading to a mallet injury. If there isn't a nail bed injury or a need for an internal fixation, it usually heals uncomplicated. What are some of the complications of P3 fractures? Could be terminal extensor lag, meaning that the fracture led to an avulsion of the extensor tendon that was missed, and then we end up with a terminal extensor lag. There could be some persistent pain and hypersensitivity or deformities to the nail bed. What are some additional treatments? They're immediately splinted in DIP extension. If there is that terminal extensor injury, we could begin active range of motion roughly 3 to 6 weeks following the injury, depending on how bad the fracture was, as well as the method of fixation. Working on edema control, blocking exercises. We have to eventually desensitize the area and perform passive range of motion. Just remember that we want to be careful because typically the terminal extensor tendon is weaker than the flexor digitorum superficialis, so that an imbalance can be created. So we want to avoid aggressive gripping and isolated DIP flexion, because that could cause an avulsion on the other side, the extensor side. So typically, what are some of the recurrent themes or interventions in some of the problems that we see when someone has sustained either a hand or a finger fracture? So the exercises or interventions include joint blocking exercises, composite flexion, meaning flexion at maybe at the MP, PIP, IP, and DIP, doing tendon gliding, which I'll show you shortly, edema control. Most times our hands in a dependent position, so getting all that fluid out of there is going to be imperative. Functional position in a splint, this way they could stay in that position for an extended period of time and they have less adverse effects of immobilization in that position as opposed to others. Doing early active range of motion, serial casting to continue to work on range of motion, scar massage, and buddy taping when the fractures of the phalangeals are non-displaced. The continued problems that we see are rotational deformities, extensor lags due to an avulsion of the extensor tendon, adhesions of the tendons onto the bones that are healing, contractures, essential slip injury, and a boutonniere deformity. PIP injuries, sprains, fractures, and dislocations. There's a wide range of injuries that can occur here, beginning with sprains, going on to fractures, and then dislocations. Some of the complications include joint contracture and extensor lag. The central slip can become injured. And when that central slip becomes injured, we could get a boutonniere deformity, having that flexion at the PIP and then extension at the DIP. So the treatment strategies are based on the complications that are seen. So when you have a patient who's had any kind of finger injury, there's a list of questions that you really want to ask, and that's once again why it is important for you to have a good relationship and good communication with your referral base. So what type of fracture and where was this fracture located? What was the method of reduction? Is the fracture now stable? Were there any other soft tissue structures involved? Can passive stress at or near the fracture site begin? And when can strengthening be initiated? Okay, so that's the end of our wrist and hand pathology. I just want to spend a few minutes talking about some generalized interventions for hand and finger pathology. So in the acute or the early stage, edema and inflammation control is big. As you can see on the top left, that's actually a picture of a patient with lymphedema. We have to get that fluid, begin to get that fluid to come down a little bit. There's certainly compressive garments, either wrapping or even sleeves, that can be utilized. Scar management, because if that scar does not move properly, there'd be adhesions underneath, limiting motion and soft tissue flexibility. Protecting the joints in this early stage to prevent further injury. So edema reduction is a very big challenge because most of the times our hands are in a dependent position. So we're going to elevate the arm, do some retrograde massage, use various techniques for compression, including wrapping. And don't forget, active exercise is your best pump to decrease the fluid buildup. So functional phase, so we've moved on from the acute phase, now we're in the functional phase. We'll be focusing on attaining range of motion, pain-free, full range of motion, restoring joint kinematics, progressively improving muscle strength and neuromuscular control, and working on the typical force couples. Eventually, what we typically do during this functional phase, again, are joint blocking exercises, composite flexion, tendon and nerve gliding, continued edema control, splinting, early active range of motion, and serial casting. So this is a picture just showing you some active joint blocking exercises. So in that first picture there, what you're doing is actually stabilizing the PIP and having each finger bend at the PIP and then the DIP, and extend at the DIP and then the PIP. Tip joint flexion, making sure we're getting isolated movement at the DIP. We could also isolate flexion. If you see in the bottom picture there, you're holding 3 fingers straight and you're bending 1 finger. Tendon gliding exercises is having your patient go through a sequence of movements that allow the particular tendons to glide across the various joints of the wrist and hand. So in the first, you have all your MP and your PIP, IP, and DIP joints are in full extension. Then we flex at the MCP, PIP, and then you make a full fist, a straight fist, and then a platform position where the MP is flexed to approximately 90 degrees, and the IP and the DIP is 0. And the second line there is just giving some interim, so you go from straight to a hook fist, then back to straight to a full fist, then back to straight, then a straight fist, then back to straight, and a platform position. And here, once again, we're showing you the functional resting position to place an individual in that will minimize the deleterious effects of immobilization.